Delighted to have Dr. Eleanor Hay joining us, who is a consultant in clinical genetics and genomic medicine at Great Ormond Street Hospital. And she actually is the RB geneticist for London. So many of you may have met her already.
So hello, everyone. Thanks so much for coming today. And thanks, Petra, for that lovely introduction. So as I said, my name's Ellie. I'm one of the geneticists who are attached to the retinoblastoma service. So I work out of London and have my counterpart, Manisha, who works in Birmingham. And we cover the National UK retinoblastoma service. And so as Petra's already mentioned today, this is an overview. We can't sort of condense all genetics of retinoblastoma into one session, but we hope what we're speaking about today will be useful and perhaps be that sort of thing that makes you think, actually, maybe I should be having a discussion with one of my clinical genetics team or one of the clinical nurse specialists about any aspect of yours or your family's care. Because clearly every family is going to be individual. So I probably won't get through all of my slides today, so I'll try and focus on the ones that I think are probably the most useful. So this is, it's a rare tumour. It's one that, actually you can see my pointer here, that begins in the retina, so these cells that line the back of the eye. And we probably have about 40 to 50 cases a year that are diagnosed in the UK. And for those individuals who have the tumours in both eyes, it tends to be a presentation before the age of 1. And for those who have just one side of retinoblastoma or unilateral, that tends to be a bit later, so more like sort of 2 to 3 years. And as we'd already mentioned, actually, in developed countries such as the UK, the cure rate is really very, very high. I don't need to tell those people here about the different ways that retinoblastoma can present, but clearly it's really quite broad. And what we used to see most commonly was this white reflection in the eye, often after photos. But since we've had the removal of red eye, this is actually one of the less common causes. So we do see people who've noticed it themselves, but actually, as you can see there, there's a lot of other ways in which the tumours can present. And actually, CHECT have been absolutely brilliant in raising awareness. So both with families, but also with clinicians, to make sure that they know what they're looking for and to make sure children are referred in a timely manner. One thing I did think would be useful to do, and apologies for those where you might have reduced vision in looking at the diagrams, but I'll talk through it as much as I can, is about the terminology, because I think it does get really confusing. And so you might find that people are talking about unifocal and multifocal retinoblastoma. And what they mean by that is unifocal just occurring in one spot in one eye, and multifocal being just in one eye, but perhaps in more than one location. So often multifocal disease is what we would call the more genetic type, but actually you can have seeding. So you maybe only have one tumour, but that's spread to other parts of the eye. So that's focal, multifocal. Whereas when we talk about unilateral and bilateral, we're talking about whether you've got one eye involvement or both eyes involved. And again, that can give us a little bit of an indication of whether we think this might be a genetic or a heritable type of retinoblastoma. And then trilateral, which is a much rarer presentation, but when individuals have both eyes affected, but also the pineal gland, which is a small area within the brain. The other thing we talk about, I think, or the terms I use, are sporadic and familial. So when we talk about sporadic, we're saying it's the first person in that family to be diagnosed, whereas familial is where it's something that we've seen in another family member. So that could be a parent passing on to a child, for example. And then we also talk about something called reduced penetrance in a few families. And this is an interesting one, and we might be able to touch upon it later, where we have a genetic change, but it's one that even if you carry it, you don't necessarily develop any symptoms in relation to that. And we're not entirely sure why this happens, but we suspect it's because the type of genetic change is maybe a milder one, so one that doesn't quite have the same impact. And so in those families, what you might see is that you could have a grandparent affected, a parent who doesn't appear to have any difficulties, and then a child who has the retinoblastoma. And so this can be quite tricky when you're sort of talking about, who might be at risk in the family. And that's where our genetic testing really comes into its own, because we can diagnose people through the genetic test rather than by looking at their eyes. The other thing I thought I touched upon, and I think we had a question in relation to this that we might be able to come to later, is mosaicism. And so this really is when you have different cell types within the body. So for the most part, when we're formed, when we have the egg and the sperm from the embryo, all of the cells that are generated from there are going to copy out their material. So they're going to be effectively identical. So you have cell types which are all effectively the same, and they're just copies of each other. Occasionally, what we see in very early development, so after the embryo has formed, is that perhaps one of those initial 8 cells develops a genetic change by chance, just by a copying error. And so say that's one of our red ones. So that when that embryo is developing, all of the cells that had the 2 copies of the standard retinoblastoma gene go on to develop perfectly in the standard way. And then these ones that have got a change will go on to have this genetic change present in all of the cells that grow from here. So the mosaic, in that you've got 2 types of cells, one where you've got 2 standard copies of the gene, and one where you've got a standard copy and one with a gene change. So we would only expect people to develop a retinoblastoma if they happen to have one of these cells in the back of the eye, which got the genetic change. So some people who are mosaic present a little bit later than we might expect for a genetic or heritable tumour, and they might only have it in one eye, because it really depends on whereabouts in the body these cells are located. And that has an impact as well as to whether they pass it on, because if these cells that have the gene change are present in the sperm or the egg, then they could pass it on to the next generation, so their children. But if it's not, if they've only got these cells which are present in the eggs and the sperm, then they're not going to pass that on. So that can have an implication when we're talking about family planning with those particular families. So just to get clear in our minds about the difference between the genetic and the non-genetic, because I think this is a really difficult one to sort of conceptualize. And the non-genetic, or what we call a non-heritable, you start off, and this is so apologies to those who can't see my very big diagrams here, but I have 2 copies of the retinoblastoma gene, and they're the standard copies, so ones that we would expect would work perfectly functionally. And then if by chance in one cell at the back of the eye, we knock out one of these copies, that's okay, because it's one of those genes where actually having one copy of the gene is sufficient that it doesn't run into any problems. But if completely by chance in that exact same cell of the thousands of cells that we have at the back of the eye, we knock out the other copy of that retinoblastoma gene, it actually can't do its job. And as the video told us earlier, its job is to stop cells from dividing out of control. So if this is the case in one cell, what you develop is a tumour. But the chances of knocking out both of those genes simultaneously in one cell are so small that actually people with the non-genetic type of retinoblastoma tend to just get one tumour in one eye. So the sort of unilateral unifocal presentations. But this contrasts to those who are genetic, or the heritable type, which is just under half of the individuals that we see. And here we have the 2 copies of the retinoblastoma gene present from birth, so in every cell in the body, one of which is the standard type, but one has already got a genetic change in it. But as we said before, having one copy that's working is perfectly fine. So it'd only be if they knock out the other copy of that cell, of that gene, sorry, in the cell, that they could go on to develop a tumour. But as you can see, this is one step closer to developing a tumour. So it's much easier for a genetic change to creep into a cell. So what we tend to see is that people with the genetic type of RB, or retinoblastoma, tend to get more than one tumour in more than one eye. And they can potentially have the trilateral retinoblastoma, where you have the involvement of pineal gland, though this is rare. So when we have individuals who've got bilateral or trilateral presentations of retinoblastoma, we know they fall into this genetic camp, because they must have a predisposition to developing the tumours if they have that many. With individuals who present with unilateral retinoblastoma, most of them are going to fall into this non-genetic type, but about 10% of people might be this genetic type, but they've only formed one tumour for various different reasons, some of which are the 2 things that I've just mentioned. So if you're mosaic, so if you don't have this gene change present in all of the cells in the back of the eye, you might be less likely to develop it. Or if you've got one of these milder changes in the genetics, so that it doesn't seem to have as big an impact. So those individuals might only develop one tumour over their lifetime. The other thing I just wanted to mention is that, with the genetic team, obviously we don't do this sort of testing and counselling alone. We form a really quite considerable multidisciplinary team involving lots of different people. So our clinical scientists, our geneticists, our Czech colleagues, our play specialists on the ward. And just to give you an overview of the sort of number of people who are involved, this is just who we might see on a day-to-day basis in our team in London, but clearly we've got the complete equivalent that is running in Birmingham as well. And the screening program is slightly variable is slightly variable between the two sites, but effectively the same. That if we've got children who are felt to be genetic, so either we've found a genetic change in them or they're bilateral, then we put them on the high risk screening pathway. So they have much more frequent screening, generally under a general anaesthetic, so that we can have a really good look at the back of those eyes and pick up any changes very early so that we can treat them promptly. Whereas those individuals who we think are at low risk, so either we've got a parent with a unilateral tumour or we've got no genetic changes within that family, they don't have as frequent screening, and often these ones can be done awake. And so I'm not going to dwell on this slide because we haven't got enough time today, but I just thought it'd be useful because I wasn't quite sure of what age group we would have across the spectrum of today, actually checking into this meeting. But we have changed the way in which we manage how we treat retinoblastoma considerably over the years. And this is important because it actually has implications for things such as the second tumour risk. So really, if we go back to the 70s when we started treating this condition, it was very much with this external beam radiotherapy, and that gave an increased risk of the second tumours, much more so than other means of management. Whereas over the years, this has gradually reduced, and actually anyone who was treated after the sort of 2000s will have had their chemotherapy as first-line treatment for most of the bilateral presentations, and for those that involve the important part of the seeing part of the eye, the macula, but then also far more use of the local topical therapies. And these are not the same sort of risk of inducing these second tumours as others. So I just wanted to highlight that because that will clearly have an implication for what we counsel families on sort of later down the line in terms of their risk of developing other tumours, and also in relation to sort of follow-up. So I know there were a few questions about the type of genetic testing that we do, so I thought we'd just have a little slide on that. So mostly when we do genetic testing of individuals, and we know that they're the heritable form, so people who've got the bilateral retinoblastoma, what we're looking for is a spelling mistake in the one copy of the retinoblastoma gene that we're expecting to find in the blood because it's present in all of the cells in the body. And effectively, it's as simple as, if you're reading through the code of this gene, there being a change of one letter for another, or there being a deletion of a few of these letters, that means that the gene just can't do what it should do. So that's the most common thing that we see in individuals who've got the genetic type of retinoblastoma. But occasionally, and there was a question about this, I think, that we had delivered through our sort of pre-session chat, to say about deletions, so chromosome 13 deletions. So when we talk about genes and chromosomes, we can sort of use the analogy of bookcases. So if you think about our chromosomes as being our bookcases, they hold all of our books or our genes, and those are the ones that are giving our body the instructions of how to grow and develop. So you can have a genetic condition because of a change within one of the books, so a gene change, or one of the chromosomes. So what can happen is this, where the gene is located on chromosome 13, there can be a missing bit of one copy of that gene, of that chromosome, sorry. So it removes one copy of the retinoblastoma gene, but it might also remove some of the books, some of the genes on either side of that. So depending on the size of the deletion that's involving chromosome 13, really depends on the sort of presentation that people have. So sometimes if it's only just taking out the retinoblastoma gene, or maybe one or other either side, they may just present with retinoblastoma. But children who've got much bigger deletions of this region, where you've taken out many, many more of those genes than our instruction manuals for lots of different things, might present with different features. So they may have problems with their growth, for example, developmental problems. Sometimes there can be impact on other organs, so say like kidney changes and things like that. So with children who have the deletion, the chromosome 13 deletion type retinoblastoma, we sometimes do a few more investigations to make sure that there isn't anything else that we need to be aware of. And then one question again that we had in the chat, we might have time for it at the end, is what if it's a VUS? So a VUS stands for variant of uncertain significance. So very often when we do the genetic changing, testing, because we've got lots of experience with this, our clinical scientists can say, yep, this is absolutely the cause of the condition in this child, and we are confident that we understand why it's happened, and we will be able to offer that test to other individuals. Occasionally, and it's usually only once or twice a year, we find a genetic change that we're just not sure of. And that's because there's not enough evidence to tell us that it's definitely doing or having a negative impact. So it might be that we haven't seen it in other individuals with this condition, or we can do sometimes some special genetic sort of functional tests, which can tell us, is this particular change impacting the function of that gene? But sometimes we're left in a little bit in limbo in that we're not quite sure. And when that happens, it's very difficult to really be certain of what is the right management pathway for these individuals, and we tend to err on the side of caution. So if we can't completely rule it out, then we would continue to screen a child just on the small chance that we might develop something in the future. And what we try and do then is revisit it when they're older, and perhaps when they're in a position of starting their own family, to say, well, what do we know about it now? Are we able to say, absolutely, this is a benign change, it's not causing any problems? Or conversely, do we actually think it might be having maybe a low-level impact on the gene? And then we can counsel families on that basis. And why do we do testing? Well, for a couple of reasons. So one, of course, we want to know whether that somebody's got a predisposition to the retinoblastoma, so whether it's going to give them an increased risk of further retinoblastomas, and whether it's going to have an impact on our counselling in terms of the risk of second tumours, which I'll come to later. But we also want to really give information for the parents to see, well, what is our chance of having another child with the same? Will we be able to offer any particular testing to either around a pregnancy or to a child who's being born? And will that be able to change the management or screening protocol that we have for that child? And then clearly, sometimes it will have an impact on the type of treatment that we're going to offer and our sort of long-term prognosis in terms of what we're expecting to see in response to treatments. And in terms of how and what we test, so I've mentioned already about blood testing. So anyone presenting with retinoblastoma, we do a blood test on to look for those sequence changes, so a change of the spelling, or also to see whether there's a change with a deletion or a chromosomal change. So that's within the blood. The other thing that we can do if a child has had an enucleation is send the tumour tissue off for analysis too. So as we said, if anyone's got a retinoblastoma, of their 2 copies of the retinoblastoma gene, both must not be working. So in a tumour, we're expecting to find 2 copies of the gene with a change in it. If we do that, we can then test their blood, because if we definitely know what the cause is in the tumour and we do not find it in the blood, we can be much more reassured that that individual is likely to have the non-genetic type of retinoblastoma. So those are the 2 main ones that we do. And then you may have heard of NIPD, which has only been available really since last year. So this is the non-invasive prenatal diagnosis. I've just got a little image of it here, which again is taken from the Czech website, actually. And what this is basically a test in which, when a lady is pregnant, you can take a sample of her blood, and from that actually separate out the small amount of circulating DNA or genetic information that's come from the baby, from the fetus. And then the laboratory can test that genetic information for a retinoblastoma gene change if one has been found in the family. So if you have a child who's been previously affected, or you have a parent who's got a known genetic change, then sometimes, but not in all cases, we can actually test during a pregnancy. So that's a very new type of test which has become available for a certain cohort of families with this condition. The other thing that we can do in some families, even if we don't have a genetic change, is something called linkage. And this is very complicated and definitely worth having a chat through with one of the team if it's something you'd be considering. And this is basically where we have a family where parents are unaffected and we have a child who's got retinoblastoma, but we haven't found a genetic change. So we haven't got a test that we can offer in pregnancy, and we haven't got a test to offer a new child. But what we can do is look at what inheritance of retinoblastoma gene this individual has got. So as we said, we've all got 2 copies of the gene. So this individual happens to have got their 1 copy called A from dad and 1 copy called C from mum. So when we test this child here, the new baby, we can say, well, do they have either of these genetic these copies of the retinoblastoma gene. And if they did, we wouldn't be able to say that they wouldn't be at risk of retinoblastoma, so we'd have to continue screening. But there'd be a 1 in 4 chance that this particular individual might inherit the other copy of mum's retinoblastoma gene and the other copy of dad's retinoblastoma gene. So if that was the case, that child wouldn't need to have their screening. So that's one thing that we can offer to families where we haven't found a genetic change within the family. So I want to give lots of time for questions, so I won't spend lots of time doing this, but I just wanted to highlight a little bit about the stages where I'm aware that I'm meeting with families and when I think it might potentially be useful to touch base with individuals who have retinoblastoma, or of parents who've got children with retinoblastoma. And clearly one of the most common times that I see people is after a child's been diagnosed. And often I do that after I've got the genetic result, because there's an awful lot to take in when you get that first diagnosis. And really what my role is to discuss what the diagnosis is, what the genetic results mean, whether we're looking at more of a genetic or a non-genetic type presentation, and then talk through the implications, not just for the child, but clearly for other family members, and if it's relevant, to organise testing of parents and of any siblings, or arrange screening, which is what we sometimes do. The other thing when I often see families is around a pregnancy. So either it's that they're thinking of starting a family, in which case sometimes we see people to talk about what their options could be, and also include in that the PGTM, which used to be called PGD, or pre-implantation genetic diagnosis. So basically an IVF procedure, which is relevant for some families where you've got a known genetic change in a parent and they are wanting to not pass that on to the next generation. But we also see lots of women when they're pregnant. And so that can be a useful time to touch base and just ask what they would like to do in terms of testing within the pregnancy. So I've already mentioned the NIPD, which is relevant for some families, but also if we have a genetic change in the family and we're not going to do anything during the pregnancy, then we can arrange for cord blood to be taken after the baby's born. So we're not actually having to take a blood sample from the baby themselves. This is just taken from the placenta, and we can turn around the results of that test in about 7 to 10 days. So usually what we find is that we actually have a result before we'll be offering the first the first evaluation of that baby's eyes. And there's a couple of ways that we can offer the cord blood testing. Either we've got a germline, so present in all cells, retinoblastoma gene change in a parent or a sibling, and we can offer that test to the child. Or we found in the tumour 2 different genetic changes, and we can offer testing of those particular targeted genetic changes in the new baby. Or we can potentially try this linkage, which is what I mentioned before. So where we haven't got a genetic change, but we can see whether the new baby has a different combination of the retinoblastoma genes from their parent, which would mean that they wouldn't be at risk of developing a retinoblastoma. And for those chats that I have with couples who are pregnant, we provide a letter for the midwife so that they know exactly what they're doing, and we provide a pack. So with all of the information, all of the things that you would need for collecting a blood sample and sending it back for us for analysis. The other thing I thought I'd touch upon just briefly was transition clinic. So we'd say to all people that when we meet with children, they're really young. So we have all of our conversations about retinoblastoma with the parents. And actually at some point, children are going to want to know, well, what does this mean for me? And I'm not sure that I understand this. And, you know, what does it mean about having a family? And actually it's really helpful if we see people around the age of 15, when they're sort of transitioning over to adult medicine, explore their understanding of retinoblastoma, talk about what it means for them in the future, what it means for planning a family, but also touch base with other things. So are they checked in with the charity groups? Are they getting the support they need within school? Is there anything else which they're missing out on, which we could potentially link them in with? And we also use that as an opportunity to refer them out for our late effects clinic, so the sort of follow on from the eye clinic, as it were. And I think possibly we've mentioned that then. So this is the other thing. Sometimes I just have people who've missed out on testing. So maybe you were diagnosed 30 years ago, you never had a genetic test yourself, but you're thinking of starting a family now. And so I'm very happy to meet people and talk about that and organise testing if it hasn't been done, talk about what might potentially be on offer for them. And refer people on to what we call the late effects clinic. So there'd be an equivalent in Birmingham, but in in London, we have one at UCLH, and it's run by an oncologist. So we've spoken a lot about retinoblastoma, so the risk of eye tumours, but with people who are genetic or heritable, where they've got a genetic change present in all of the cells in their body, there is a much smaller risk of second tumours. So this is part of the reason for going to the late effects clinic. So one is that they monitor for the side effects of chemotherapy or radiotherapy, which is much less now, as we mentioned before, because we're not doing the external beam. But they also talk about the risk of second tumours, which are they're not as frequent as we see the risk of retinoblastoma. It's almost the opposite risk. So most people never develop these, but we need to be aware of them because they are eminently treatable. And the types of things that we see are skin changes like the melanomas, so moles that are funny shape or size, and lumps and bumps appearing. So that's in bone or soft tissue sarcomas. And we tend to have recommend a low threshold for seeking review. So from your GP, from people in the late effects clinic, from touching base with clinical nurse specialists, just so that those things can be reviewed quickly. And if there is something that needs to be done, that it can be done in a timely fashion. And there's been various studies that have looked to see whether there's an efficient screening program available for this, but actually we've found that having a low threshold for seeking help and for taking sensible measures in terms of your health are actually just as effective. So really highlighting if there's any changes, and we tend to say that most of these occur after the age of 10, so it's not in the early childhood period where the eye risk is the highest, and about half by the age of 25. And the recommendations that are given currently are just lifestyle advice. So making sure that you are checking in regularly with somebody, making sure that you're taking care in the sun, avoiding any radiation. That includes the use of radiotherapy, smoking, having a healthy diet, things like that. Oh, sorry. And that's all discussed at the late effects clinic, as well as the other things. So things about reproductive health and how you're managing, in schooling or obviously later on going to university, anything else that you might need support with. So it's a really, really useful resource, actually. And I think that was the end of my slides. I'm aware that I have gone on longer than I had, longer than advertised, so apologies for that. But very, very happy to answer questions. And I know you're going to put up contact details and things at the end, Petra. So I'll stop sharing so that I can see people, because I seem to have lost all of my all of my videos when I have my slides up. But yes, let me know how you want to answer questions.
All right. Lovely. Thanks, Ellie. Wow, that was fantastic. And I know that you've covered a lot of the ground of what some of the questions that people sent in, but I think on some of them we might just do it again, because I know with myself, repetition, it just needs to keep going over it for it to go in. So we might cover some of the same ground, but I'll try to focus on questions that perhaps we haven't done so far. So number one says, I have two children. The youngest has genetic bilateral RB, the oldest does not. Myself and the mother have been tested and do not carry the gene. Is there a chance that the oldest child could carry the gene, even though he does not have RB?
Okay, well, that's a good question to kick off with. So when we were speaking before about the genetic and heritable forms, so we mentioned you can have form where it can be passed on from a parent to a child. So that's very obvious to know that that's a hereditary form. But quite often what happens is that genetic change starts for the first time in the child. So we're not seeing it in the parent, but for whatever reason, either in the sperm or the egg, or very early on in that embryo, a genetic change has come in. So all of those cells that go into forming the child will have a genetic change in it. So they're genetic and they can pass it on. Usually that started for the first time in them if we've not found it in the parent's blood. What we say is that no test is completely accurate ever. And what we don't test for is every cell in the body. We're doing the blood test from the parent's blood. Yeah. So there's a small chance, we say it's less than 1%, that genetic change that you find in the child might be present in the sperm or the egg of the parent. So it's less than 1%. Yep. And so for that reason, if a new child was born to that family, we could test that new baby for the genetic change and then be 100% sure they didn't carry it, and we'd remove that 1% risk. So the chances of the older child
Oh no, just frozen again. Hopefully she'll be back as quickly as she was last time.
Am I back?
Yes, again, it was just a
Sorry.
30-second blip. You just started to say the
I was,
chances of the older child.
yeah, okay, good. Thank you, Petra, for putting me back in. Yeah, so the chance of the older child being affected would be really low because there'd be a less than 1% chance that a parent was a carrier, and then that would be halved of them passing it on. And then the child to be older and not develop a tumor, infinitesimally small, but we can always test that older child if there was parental anxiety. So we could always test them for the genetic change that had been found in their sibling. And if it wasn't found, we could be absolutely sure that they didn't have the genetic type and that they couldn't pass it on to their children.
Okay, great. And when a unilateral sporadic case of RB is enucleated and no further treatment is required, is any genetic trace or record of the RB remaining in the patient?
Okay, so that's another really good one. So this is we're talking about a non-genetic retinoblastoma, so one where the no genetic change has been found in the blood and we found it within the tumor. So we know that that has happened by one cell at the back of the eye. So that's only that one cell which is having the retinoblastoma gene changes. So provided the eye has been taken out and there's no spread on the optic nerve, which is why they do all of the histology and they talk about whether a child needs chemotherapy and things like that. If there's no invasion of the optic nerve and the eye is completely removed, there is no more risk of retinoblastoma or anything else within the body. So if there's no spread from that eye and it's non-genetic, then no, that is removed and that's the end of it, as it were.
Okay. I understand that my child is at risk of developing a second cancer in the future due to their faulty RB1 gene, but is it not certain that a second cancer will develop? And I think you've
Yeah,
covered this,
so
but it's
that's where
useful to
yeah,
re-emphasize
it
this.
is useful, and I think it's particularly useful because the information on the internet is very poor because it's often based on studies that are very think back to what I showed you, that image of the way that treatment has changed over time. So if you were treated in the 70s and 80s, you would have had very high dose external beam radiotherapy because that was felt to be the most reliable way to treat it at the time. And that really led to a significant number of second tumors occurring around the field that the child was irradiated. So they used to say the risk of second tumors could be as high as 30%, but that was based on data for individuals who were treated then. We don't have brilliant data now because it's just quite difficult to collect things, but we don't see anything like that number anymore. So the figures that were used to be given by my consultant, who Dr. Rosser, who many of you will have met, who worked in the service for 20 years, she felt was much more like 6%. So a much lower risk of developing these tumors. So the vast majority of individuals with genetic retinoblastoma do not develop a second tumor. We just know that risk is higher than the general population. So we always will say to people, this is a theoretical risk, and we can't say who will get one and who won't. So you just have to have that, heightened sense of awareness for these things, have a lower threshold to seek review of any of these unusual changes if you. But actually the risk is nothing like the same as your risk of developing retinoblastoma, which is very, very high.
Yeah, I think that's really important, isn't it, to be aware of that. What is the probability of a naturally conceived child getting retinoblastoma if one of the parents has hereditary retinoblastoma?
Okay, so if we've got known hereditary retinoblastoma, so a parent has one standard copy of the retinoblastoma gene and one that has a gene change, with every baby that they conceive, there'd be a 50-50 chance of passing on each of these. So there's a 50% chance of passing on the standard copy and that child not being at risk of retinoblastoma, and a 50% chance of passing on the one with the gene change and that child developing retinoblastoma. So it's a straight 50-50 if the parent has got a known genetic carrier of the condition.
Okay, and following on from that, what are the chances or risks of a second child having the same condition if we decided to have another, and how is that managed, assessed?
So that would depend on whether a parent was found to be a genetic carrier of a gene change. So as we said before, if neither parent has the genetic change that's been found in the child, the risk is going to be less than 1%. If the parent has the gene change, so there's one copy that's standard and one with the gene change, it would be 50-50. So it depends on what's been found in the child and whether that change has been found in the parents.
Okay, lovely. And for you talked a little bit about mosaic retinoblastoma earlier. We had a question. Could you discuss mosaic genetic retinoblastoma and the current or near future options available for genetic testing for women with a mosaic form wishing to conceive?
So with the mosaic form, we're saying that a parent has got genetic blastoma, but not every cell. So they might have some of their cells which have got two standard copies of the gene, and some cells which have got one standard copy and one with a gene change. But as I said before, we can't say in which tissues are like this and which are like this. And so that means that we can't say whether the genetic changes could be present in the egg, because we can't remove that and test it and put it back. So for individuals who are planning a pregnancy who have got the genetic change, there are several options. So there's the pre-implantation genetic diagnosis we mentioned. So that's going down the IVF route and only replacing embryos which do not have the genetic change. So people are eligible for that on the NHS for one baby, one unaffected child, and with various different eligibility criteria, etc. But that is one way. Another way about testing in pregnancy is through the invasive test. So that's taking a little bit of the placenta at around 11, 12 weeks of gestation and testing to see whether the genetic change is found in the baby. We tend only to offer that if somebody would be thinking about not completing a pregnancy if the baby was affected, because there's a small risk of miscarriage procedure. So the alternative, which is available for some people, is to have that NIPD test. So to take a sample of the blood from the mother and to look and find the genetic information from the baby, the fetal DNA, and to test that. But that is much more challenging for the laboratory if the mother is the genetic carrier. Because if you can imagine you've got blood from the mum, 95% of the DNA in mum's blood is going to be from mum, and only a small fraction of that is going to be from the baby. So when they do that sort of testing, it could be very difficult for them to say whether the result they've got is from the mum or from the baby. So if anyone's thinking about NIPD, I would say what we need to do is speak to a geneticist early so that we can have a liaison with the laboratory and see, well, is this possible? What would we need to set up beforehand if we were to make it happen? So that definitely doesn't work for everybody, but is an option for some. And then the alternative is to test after pregnancy. So doing the cord blood sampling that we mentioned before. Anyone is a genetic carrier of retinoblastoma, we know that their risk is 50-50. If they're mosaic, we say their risk is less than 50-50. You can't put a figure on that. So it's going through the options with each individual about which would feel most right for them as a couple. And it's definitely, there is no right or wrong in this. It's very much how you feel at the time as a couple proceed with your family planning.
Yeah, that's absolutely, it's such an individual thing, isn't it? This is a slightly longer question. Someone says they're unsure about the process of having children. I was told I was eligible for gene selection when having children of my own, and was told I would have an appointment with a geneticist about this. I was told this at 16 when I was discharged from paediatrics at the Royal London. I'm now 21 and haven't had an appointment, nor an oncology checkup since Dr. Kingston's passing, and Adam Brooks will not accept me for late effects clinic. Basically, some clarity on the process of starting a family in the future. There's actually a couple of issues in there, aren't there? I'll
There
leave that
are,
one
and
to
I
you.
think with all of those things, the big one is if you haven't heard from somebody, you don't know who to get in touch with, speak to you guys checked, speak to the clinical nurse specialist at Birmingham or London, because they are the absolute fonts of all knowledge. So they will let you know what the pathways are for getting into these things. So for the late effects clinic, which is part of that question, if they're been seen by us in our area, they can be referred to the UCLH late effects clinic with Dr. Lynn Riley. So she's the oncologist who'd be very happy to meet people yearly. Doesn't have to do it in person. She quite often does it virtually, but we'll see people if they want to be seen. So that's the late effects side of things. In terms of talking about family planning, wanting to just recap on implications for their own health, equally, I'm very happy to see those individuals in our region, and I'm sure my counterpart in Birmingham will be exactly the same. What tends to happen is people get in touch with Charlotte, Laura, and Claudia and the team in the Royal London with Maxine, and then they will let me know and say, this person hasn't been seen for several years. Please could you contact them and make a suitable appointment? And again, I sometimes see people face to face at the Royal London. Sometimes we do things virtually. We've done things over the phone. Very much, amenable to any of those things. And then anything comes up from those conversations, we can then generate the relevant referrals. So, making sure they're seen by late effects, speaking to the team at Birmingham if they want to think about NIPD, or talking through what we would do in cord blood testing, what the process would be if a baby was born with RB, and how they would be managed at the Royal London, that sort of thing. So I'd say that definitely the first step is to speak to get in contact with the clinical nurse specialist at the relevant centre.
Okay, great. And what does it mean when genetic tests are inconclusive? Do you do regular follow-up tests on the tumour if it's been enucleated, or blood test if the initial genetic tests were inconclusive?
Are really tricky. We have lots of tissue. In fact, even now we've got research samples that are being reanalyzed from 1994. I occasionally get a report that filters into my email, and so for the most part, if we're doing testing now, it's the best testing that we can offer. And so reanalyzing anything in the next couple of years probably isn't going to make a lot of difference. But there will be some individuals where, as I mentioned earlier, you have a variant of uncertain significance. So something which we're just not sure about. So it might be a rare change, but one that isn't likely to impact the function of the gene. And we just can't be certain whether it's contributing to the risk of retinoblastoma or not. And in those cases, we tend to take a sort of pragmatic approach. So we don't ever want to risk not screening somebody who might be at risk. So we would err on the side of caution. So we continue to screen a child who had a variant of uncertain significance. But what we would say is when it's next impacting the family, we'll revisit it. So if the family in 5 years' time are thinking, actually, I'm going to have another child, then that might be the time that we revisit this evaluation and say, well, what's new in the literature? Has this variant been reported anywhere else in the world? What do we know about functional studies that might help us understand whether it's relevant or not, so that we can then counsel the family on the risk of having another affected child? Similarly, when that child is grown up and they're thinking about starting their own family, that's often 15 years later, and we're much more likely at that stage to be able to get some sort of resolution. So either, no, this is completely benign, it's not causing any problems whatsoever, we don't know what caused your retinoblastoma, but it's likely to be by chance. So they would have a child on a low risk screening pathway. Or equally, nope, this is definitely disease causing, this is what's caused your retinoblastoma, we can test babies to see whether they carry this genetic change. So we do revisit it, but we tend to do it at choice, regions along the pathway. Oh, you're muted, Petra.
Thank you. I thought I was going to get through the whole session without doing that. This is slightly covering the same ground, but I think, again, important to re-emphasize. Someone says, my son, who lost his left eye to RB aged 10 weeks in 1993, is not interested in this topic at all at the moment, but I feel it's important to understand the likelihood of him passing it on if he decides to have children of his own in the future. Would his own tumour sample still be available for analysis, or are they long gone by now?
Well, he may be in one of my 1993, 1994 tumour sample reanalysis cases. So the gene was only found, in the late 80s. So routine testing wasn't available around then. So there was a lot that was in a research sort of department, and that's all been sent over to the Royal London. So there is actually ongoing testing of tumours. It's not always brilliant because these tumours are old and sometimes the samples are just not suitable for testing. But what I would say is for that family, that to get in touch with the clinical nurse specialist and say, it would be worth having an appointment. Nothing has to come of that. It can be a very light-hearted conversation about what do you know already. Let's see what we know from our notes, what testing has already been done, what testing might be able to be offered. Because even if we can't test the tumour, we can test that individual's blood to see whether they've got any genetic changes. And that will help us in terms of being able to counsel them on the risk of having affected children and, what potentially, if there's anything, we can offer them, in terms of family planning.
Okay, lovely. There's a question about 13q deletion. I know we did go over this earlier, but someone's asking, where can they get updates and current information about 13q chromosome deletion? And the second part of that question is where they can connect with other parents who have children with 13q. Certainly, with retinoblastoma and 13q deletion, if you speak to your support worker, and we'll be sharing details at the end of this talk, we should be able to put you in touch with other parents whose children have the same condition. But Ellie, I don't know if there's anywhere they can find more up-to-date information about 13q deletion.
I think you'll have a lot of the up-to-date stuff because you'll have families who are, wanting to share that information. The other place to look, it might be worth, if I can at the end, I'll put in the chat, is the Unique charity, Unique Rare Chromosomes. And so they were initially set up in response to us doing lots of chromosome microarrays where we pick up whether individuals have got any missing or extra genetic information, so these deletion or duplications. And so as part of that, on chromosome 13, they create these brilliant leaflets which are made for families. So they're very much written in a way which is easy to digest, and actually has wonderful quotes from families about their children who've got that particular condition. And so if you contact them, they have got a whole heap of families who have given consent to share their own details so that they can be put in touch. So I would say that's another really good sort of charity to link in with if you're looking for either other families to meet up with, or equally information about the condition, because they do update their leaflets too. So it's quite a good one. And I think there are two 13q deletions. There's one that says 13q that includes the RB gene. That's the one you want.
Great. Yes, and they are a great organisation, Unique, and Sarah's just shared the link to their website in the chat. So, and I'll try and make sure I forward that on with the recording as well. We're down to the last 5 minutes of the chat. I think we could have 1 or 2 live questions if anyone has got anything they want to just quickly get on before we finish for the end of the evening. But this has been just great, Ellie. Thank you.
You're very welcome.
Have we managed to cover everything? Oh, I can see Pippa. Yeah. Go for it.
Sorry, can you hear me?
Yes.
It's a random one. So my daughter has genetic RB, but also a cleft palate. I am aware of 2 other children who have the same combination, and just, that's randomly through the RB connection, obviously not necessarily the cleft. And I'm just wondering whether there's anything about that is a link or just absolute chance.
I think for the most part it's chance. So cleft lip and cleft palate are both relatively common congenital changes that we see from birth, and we recognize they've got a multifactorial origin. So it's sort of a combination of subtle genetic predisposition plus environmental things, and we don't have a really good handle on either of those things at the moment. So we're very good, or we think we're very good, at identifying genetic changes which are caused by knocking out a whole gene. What we're not good at is looking at sort of across the whole spectrum of the genetics and saying, well, if you've got a combination of these 16 different subtle changes, you're more likely to get cleft palate or cleft lip and things like that. But it's something like 2%. So it's a surprising number of people who have cleft lip and palate. So I think it's by chance. The only thing, the caveat would be that if individuals who've got larger 13q deletions who take out other genes might be at risk of doing that. But I think probably, so I'm going to be proven wrong in 15 years' time, there's not a direct link between those two things. But what we would, that's fine. But what we would say actually is we don't always do genetic testing on people with isolated cleft lip or cleft palate, but we do if there's other things. So if we've got individuals who've got cleft lip and learning difficulties and short stature and things like that, we consider doing more. But when it's completely isolated, actually we don't do lots for those children.
Thank you.
No worries.
Okay. And the final question, Enzo, you've been very patient with your hand up there. Would you like to ask your question?
Yeah, thank you very much. Hi, Ellie. My son Marco is being diagnosed with bilateral retinoblastoma.
Okay.
And unfortunately, I am the carrier of the gene. And I've got another daughter, Olivia. And my question is, at what age would you suggest to have genetic tests on her if she would like to have babies? I mean, and how likely can she carry the gene onwards?
Always.
in
How old is she
in her
now,
life.
Enzo?
She's 7 years old. Yeah,
7 years old.
she's 7 years.
And did you ever get retinoblastoma?
No,
You didn't. Okay,
no.
so you're one of those ones that we described at the beginning, probably this reduced penetrance. So you've
Okay.
got sort of a milder change potentially. I mean, I obviously haven't seen your report. So it could be that you can carry the change and not develop retinoblastoma with it. And so what I would say is touch base with where are you based? Where's your local unit?
In London.
Okay.
And Marco has been treated at the Great Ormond Street Hospital.
Okay, so yeah, you could absolutely have a discussion with us, and we could talk you through what the options are in terms of testing. We don't withhold testing from people, because if people were found to carry this genetic change, even if it was a reduced penetrance one, we want to make sure that we're following them up. But equally, if we didn't find it, we could say, right, we've not found it in you. You won't be at risk of having children with the same. So definitely touch base with the clinical nurse specialist, and she can tap you into the system.
Can I touch base with Maxine in this case? I mean,
absolutely.
is she the person? Okay,
yep.
Fine.
She'd be the perfect person to speak to, and then we can set something up to have a discussion later down the line.
Thank you very much for all of your efforts that you do in scientific research. Thank you.
Thanks, Enzo. Right, it's 8 o'clock, so I'm afraid we are going to have to draw a line under it there before Ellie loses her voice from talking for 50 minutes. That's been absolutely brilliant. Thank you so much. Thank you for everyone for participating. As I say, I am recording this. Hopefully, if the technology's all worked, we hope to circulate this to everyone who signed up for the event by the end of the week. It will also be available on the website and through our YouTube channel. If this has sparked any questions for you, if you feel like you would really value having an appointment with a geneticist, get in touch with one of our support workers, either Sarah or Lena, and we've got their details in the chat, or you can find it on our website. They can signpost you in the right direction for making that happen. So I said, this has been the first online session of this kind that we've run. I hope you've found it as interesting, as useful as I have. I am going to be circulating a feedback form, so please do let us know what you thought, any suggestions for anything that could have gone a bit better for you. I'm sorry, I believe that for most people the animation sound wasn't working at the beginning, so I'll circulate the link to that to everyone as well, so you can watch that back in your own time. And if you have enjoyed this evening, do let us know if there are other topics that you would like us to treat in a similar way, having an expert along to talk through and have questions, very much guided by what you would find useful. So do let us know. So thank you for joining us. Thank you to Ellie and for Sarah for manning the chat, and enjoy the rest of your evening.